Good afternoon, everyone, and welcome from the PHO chapter for this weekly online teaching session, which is basically designed for the fellows. Now, today, I think there was a lot of requests and demand for having transplant topics also inbuilt in this training schedule. So we have now started putting some BMT topics interspersed between the hematology and oncology sessions. And you'll see some of these basic topics being covered in the next few weeks to come. So today we are going to do a very relevant and a very basic discussion, which is on basics of HLA typing, followed by a discussion on the donor selection. And as you know, the format, there will be a didactic which will be there for on basics of HLA typing, and then we'll do some discussion on the donor selection with the expert panel. I'm really thankful, first of all, to Neha for volunteering and moderating today's session. Dr. Neha Rastogi is a senior consultant in Medanta Hospital in Gurgaon. I'm also, very thankful, and especially to Dr. Jasmeet. Dr. Jasmeet is chief of the referral lab, Lal Pathology Referral Lab in Delhi, and we know her contribution to the lab immunology and the help she's been providing us all these years in managing our patients. So welcome, Dr. Jasmeet, and special thanks to you for taking out your time to be interacting with us today.
Thanks, Sunil.
We have also, experts to be part of this discussion. So there's going to be Dr. S.P. Yadav. He doesn't need introduction to this audience. Sir is the head of the department at Medanta Medicine in the Pediatric Hematology Oncology department. We also have Dr. Satyendra Kateva. Again, doesn't need introduction to this audience. He is head of the Pediatric Hematology Oncology department at Soni Manipal Hospital in Jaipur, and I'll be also one of the contributors to the discussion later on. So I thank again the curriculum committee, especially Nita and Anand, for putting these sessions together, and Ria, who has been coordinating them for the last so many weeks. Over to you, Neha. Once you're done with this, then we will. Sorry, I forgot Upasna. Upasna is a fellow at Medanta Hospital Gurgaon, and she's going to be presenting. She's the fellow who's going to be presenting the topic for discussion later on. Over to Neha for your didactic.
Thank you so much, Dr. Sunil. So, good afternoon, everyone. I am Dr. Neha Rastogi, and today, firstly, I want to pay my thanks to Dr. Sunil, Dr. Mamta Madam, and PHO chapter of IAP for giving me this opportunity to give a didactic lecture on the basics of HLA typing. Since this is a lecture for fellows and students, so I have kept it either basic or very, very basic. So going directly to the lecture. So once this topic is being assigned, most of you would be thinking, what is the need to read about HLA? तो few of you might be thinking कि 5 नंबर का क्वेश्चन आता है तो उसके लिए पूरा जो है आधा घंटा क्यों चटना, वो भी बेसिक लैब उस पे. But the answer is that since nowadays BMT has become a good part and parcel of our curriculum of hematology oncology, and the HLA is the basic building block to understand the immunology of the transplant, so it is important to read this HLA part also, even if it is so boring. I will try my level best to make it less boring. So now comes to the why part. So what happens is that there is a donor and there is a recipient. So when you have done the conditioning, which is done to remove the old bone marrow, then if some alloreactive cells of the host are remaining, they can attack the graft and they can kill the graft and rejection can happen. Similarly, the alloreactive cells of the graft can later on kill the host and can lead host cells and can lead to GVSD. And this is increased, the incidence increase when there is not a good HLA matching, or you can call it as HLA mismatching. So today we will learn about HLA matching so that we can reduce the incidence of GVSD and we can have better engraftment. So firstly, human leukocyte antigen, HLA. So there are two terms. One is HLA, other is major histocompatibility complex. तो क्या अंतर है दोनों में? So the major histocompatibility complex is a gene complex. Yes, क्रोमोसोम 6 पे प्रेजेंट एक जीन कॉम्प्लेक्स है जिसके अंदर बहुत सारी जीन्स है, ठीक है. उन जीन्स को हम कहते हैं HLA जीन्स, एंड द प्रोटीन्स प्रोड्यूस्ड बाय दोस जीन्स are known as HLA proteins. These are the cell surface protein. ये सेल की सरफेस पे होते हैं and they are important for the regulation of the immune system. They present the peptide to the T cells and they enable them to recognize to eliminate the foreign particles of the individual or to prevent the recognition of self as foreign. कहीं ऐसा ना हो कि अपने ही cells को खा लें. So for that also we need the recognition of self. Okay. So these natural functions need to be overcome or manipulated in order to allow the grafts between the HLA non-identical individuals to be accepted. The HLA system displays extensive polymorphism due to the need of the immune system to keep up with and control infectious pathogens. And even with the diversity in the HLA system, we are able to identify compatible donors due to the Mendelian inheritance of HLA and the presence of well-defined haplotypes and linkage disequilibrium. I will come up to this polymorphism and linkage disequilibrium later in my slides. Now coming on to the major histocompatibility complex. So, सबसे पहले, when was the immune-mediated rejection of the tissue was described? It was in 1945, before our independence. उसके बाद MHC recognize हुआ 1948 में, और HLA molecules कब recognize हुए? In the late 50s. Since then, MHC has emerged as a single most polymorphic gene locus in eukaryotes. So, now coming on to the human MHC, it is present, as we all know, it is present on the short arm of chromosome 6, and it contains about 260 genes, many of which with immune-related functions. इसके basically 3 reasons होते हैं, class 1 reason, HLA class 1 reason, class 2 reasons, और इन दोनों के बीच में class 3 reason. So HLA class 1 reason में हमें कौन से genes मिलते हैं? HLA A, B and C, और class 2 reason में हमें मिलता है HLA DR, DQ and TP. So this is a figure which is showing the chromosome 6. ये देखिए centomere, this is centomere, and this is the part of MHC, which is the gene complex. It has firstly has the MHC class 2nd reason, and then MHC class 1 reason, and in between we have class 3rd reason. This is the same diagram in a diagrammatic form. Class 2, class 1, and in between class 3. So now coming on to the structure and function of the HLA molecules. The overall structure of HLA class 1 and class 2 molecules is similar, with most of the polymorphism located in the peptide binding group, which is PBG. HLA molecules are expressed on the cell surface where they present the peptides to the T cells as antigens. So this is a diagram which is showing the structure of HLA class 1 or class 2. So class 1 mein, if we see, then it has only alpha chains, alpha 1, 2 and 3. And in class 2, if you see, it has alpha chain as well as beta chain. And the other thing is then, कि जो हमारा class HLA class 1 है, it has beta 2 microglobulin, okay, which is produced by the chromosome 15. And it gives the endogenous antigen. It presents the endogenous antigen. So what happens if a virus comes and it attacks a cell? Inside the cells, the proteasome will break it down into small molecules, and these small molecules will be presented on the surface by the HLA class 1. Where in the HLA class 2, what happens? It is exogenous antigens which are being presented to the antigen presenting cells. So we will read about the class 1 molecule. MSC reason 1. It is about 2000 kbp in length, and it comprises of 3 class 1 genes called class HLA A, B and C genes, encoding the HLA A, B and C proteins respectively. Each protein is capable of forming an alpha chain of MHC class 1 molecules. MHC class 1 molecules are present on the surface of all the nucleated cells and platelets, and they present the peptide antigen to CD8 positive T cells, cytotoxic T cells. Then is the class 2 molecule. It is about 1000 kbp length and comprises of 3 genes, DP, DQ and DR, encoding the DP, DQ and DR proteins. Each protein is capable of forming an alpha and beta chain of MSC class 2 molecule. In addition to the MSC region, also contain known classical genes such as DM, DO, etc., which help in the antigen processing and presentation. And the MSC class 2 proteins are located on the surface of antigen protein presenting cells, example B cells, macrophages, and dendritic cells. They present the peptide to CD4 positive T cells. Class 3 molecules, they are about 1000 kbp in length and not involved in antigen presentation. This part of MSC is comprises of genes that code for complement factors, heat shock proteins, tumor necrosis factor, and steroid 21 hydroxylase, etc. So this table gives us a in nutshell the difference between class 1 or class 2. Okay? So सबसे पहले where they are present, we know class 1 are present in all nucleated cells and class 2 is present in antigen presenting cells. फिर next point is ये antigen किसको present करते हैं? So class 1 presents to CD8 positive T cells और class 2 presents to CD4 positive T cells. उसके बाद nature of peptide antigen कि जो ये antigen present कर रहे हैं उसका nature क्या है? So as I have already told you, class 1 जो है वो endogenous antigen present करेगा, class 1 endogenous antigen present करेगा और class 2 exogenous. And what is the general size of bound antigen? It is 8 to 10 amino acids in class 1 and about 13 to 18 amino acids in class 2. And what is the peptide binding site? In class 1, if we can see in the figure, in class 1 हमारा antigen जो antigen binding site है वो alpha 2 और alpha 1 से बना है और class 2 के अंदर alpha 1 और beta 1 से बना है. Okay. So now coming on to the polymorphism. So what is polymorphism? So polymorphism is the presence of multiple alternative forms or alleles of a gene. And this is the polymorphism which allows the population to handle a variety of pathogens. So if we want to talk about the human HLA, so we have 2 chromosomes. Each chromosome is at least coding for 6 proteins, HLA A, B, C, DR, DQ, DP. तो 6 इधर 12 हो गए, तो 12 proteins per human being and multiple alternative forms of it, alleles. So if we see in a population, then it's a huge lot of variety of HLA which is being there, which is what it is helping. It is helping us to save us, humanity को save करने के लिए from the pathogen. क्योंकि कुछ HLA के साथ जब reaction होगा तो कुछ और तरह का immune reaction आएगा, किसी और तरीके के साथ होगा तो किसी और तरीके का आएगा. अभी कोविड era चल रहा है, तो in this COVID era few people are like having a cytokine storm like anything and few are not showing anything. उनको कोई भी symptom नहीं आ रहा. Why it is all happening? It is all happening because the God has given us this polymorphism. अगर polymorphism नहीं होता तो either हम सब बच जाते और सबके सब मर जाते. And we don't be having this class today. So next is linkage disequilibrium and haplotypes. So what is linkage disequilibrium? It is very important to understand, because it helps us in understanding when we are going for a mud transplant donor cells. So linkage disequilibrium means that there are certain alleles which occur together with a greater frequency than would be expected by chance. Okay, so non-chance random gametic association. So in layman terms, if I want to explain it, it would be like that: ki if there are 2 brothers, one is Ram, other is Lakshman. So Ram is an individual, Lakshman is an individual. Ram can go anywhere, is free to go anywhere. Lakshman is free to go anywhere. But they have a strong bond. So their friendship is very good, so they go together. So if Ram is going to one or forest, so Lakshman is also going to the one. They can go anywhere they want, but they are going together because they have they are not physically attached, but they have a strong association with each other. Okay, so this is very helpful when we do the mud searching. Now what is haplotype? Haplotype describes a group of genes which are inherited together. Certain HLA haplotypes are common in a particular ethnic groups. Okay, so it is also important to understand कि एक तरह के haplotypes कभी-कभी किसी races में ज़्यादा मिलते हैं. तो अगर हमने एक मड डोनर सर्च करना है और हमको ये वाला हैप्लोटाइप मिल गया जो कि कॉमन है उस रेस में, तो वी नो कि हम इसको आराम से हमको इसका डोनर भी मिल जाएगा. लेकिन अगर उसके अंदर कुछ रेयर हैप्लोटाइप है तो हमें थोड़ी मुश्किल होगी. Now coming on to the nomenclature, it is also very important to understand the nomenclature. So firstly we should learn the HLA terminology. So each MHC complex on a single 6 chromosome is defined as haplotype. Okay, but when we talk of both the 6 chromosomes, then it is known as genotype. So HLA locus is the area of gene on the chromosome, and HLA antigen is defined by serological method, and HLA allele is by the DNA typing. Okay, so as you all know that HLA typing can be done by serology, low resolution, high resolution. We will read about it later on, but ठीक है ऐसे करते हैं. तो जब भी हम serology method से use करेंगे तो हमारी terminology क्या होगी? HLA antigen. अगर हमने उसमें DNA methods use कर दिए तो फिर हमारी terminology हो जाएगी allele. So each HLA allele name is unique, where a number corresponding to up to 4 sets of digits separated by colons is assigned. The first digits before the first colon describe the allele group, which often corresponds to the serological antigen. Example A is asterisk 24. तो asterisk वहीं पर लगेगा जहां पर आपने DNA method यूज किया. अगर आपने serology यूज किया तो asterisk नहीं लगेगा. तो आपके पास रिपोर्ट आता है, आप देखते हो उसमें asterisk नहीं लगा हुआ, you know that it is low resolution type. Oh, sorry, it is serology type, not even low resolution. So this is the level obtained by low resolution typing techniques. The second set of digits after the first colon जो है are used to list the subtypes, different numbers denoting one or more nucleotide substitution that changes the amino acid sequence of the encoded protein. जैसे कि यहाँ पर है A*24:02. Okay. So ये 24 हमें बता रहा है allele group, ये asterisk बता रहा है कि ये जो है this is done by DNA method. This 24 is telling this is the asterisk, this is the allele group, and this 02 is telling that it is the subtype. What is the subtype? So medium resolution tissue typing techniques like SSO or SSP can define the specific allele groups and subtypes, although often as a string of possible alleles within a particular allele group. High resolution typing methods are employed to resolve the tissue type to allele label with no ambiguity. The allele name can, however, extend by several more divisions representing firstly synonymous mutations and then intronic or other non-coding variants, although these are currently not considered when selecting the donors or scoring HLA matching. The addition of an optional letter at the end of sequence indicates a major alteration in its expression. Example N for null allele. So ये example है. तो यहाँ हम पहले देखते हैं serology. तो उन्होंने क्या है A1. They have not put any asterisks. फिर DNA based में इन्होंने low resolution, medium resolution और high resolution बताया. So in the low resolution, if you see, so A asterisk 01. So 01 is the allele type. In medium resolution, they have 01:01 या फिर 01:04. So they are not. It's the medium resolution. They are not able to subtype properly. They have subtype it, but they have clubbed together जो एक से वाले proteins जो carry करते हैं उनको उन्होंने एक साथ club कर दिया. High resolution is the ultimate answer, so it is 01:01. Okay. So similarly, ऐसा ही example है other diagrammatic representation में. अगर हम यहाँ देखें तो at the starting it is all HLA के बारे में हम बात करें. Low resolution, if we are doing by DNA method, A*02. If we are doing by serology तो खाली A2 लिखना है. Intermediate में, so HLA A*02:01, 01L, 09, 343 इनमें से कुछ भी हो सकता है. ठीक है. High में A*02:01 P is for protein, similar proteins. Allelic, so this is the best one. We want to get the report like this. This is the best one which we usually get in high resolution typing 02:01:01:01. And this is also the same thing. I skipped this slide. So this figure tells us कि if we are doing the serotypes, we are only getting कोई भी एक locus ले लेते हैं जैसे DP, तो DP पे हमें केवल 6 प्रकार के serotypes मिल रहे हैं. But अगर हमने high resolution किया तो we are getting 673 types. यानी जिसको हमने एक माना था. अगर if we are getting only 6 types of serotypes, तो we can easily match this person to this person. 6 ही variable है. लेकिन actually में कितने 673 and 673 to date. As the time goes by, ये 673, 6073 भी हो सकते हैं. So we need to understand with the time passing, we are getting to know more and more differences, and they are important to reduce the GVHD to increase the engraftment rates. But many alleles produce the same kind of protein. That's the reason why protein अगर हम देखें तो 539 है, कम है allele से. Similarly, for every locus they have defined it. Now coming to this busy slide, this is for especially for the mud searching, which we will discuss in our panel discussion in a greater detail, but just for the sake of it, यहाँ पर फर्स्ट अगर हम देखें तो A*0 to A*02 यानी कि ये उन्होंने लो रेजोल्यूशन पे किया है, तो हमारा पोटेंशियल मैच ही होगा, हमें इसकी फर्दर सब टाइपिंग करनी पड़ेगी। फिर यहाँ पर इन्होंने GG कैरीज फॉर अ ग्रुप, सो दे हैव नॉट डिफाइंड इट स्पेसिफिकली, तो इसीलिए यहाँ पर भी पोटेंशियल मैच दिया है। लेकिन अगर इफ वी सी लाइक दिस, so here they have subtyped it completely 02010101 02010101, so ये पूरा हमारा मैच है। But I know this slide is quite confusing, and after this slide most of you might be thinking like what the hell it is. So don't worry, we have computer, we have artificial intelligence, they help us a lot. So अब हमें अपना माथा पच्ची करने की जरूरत नहीं है। When we send for the mud searching, then the computer algorithm do all these things for us. We need little clinical inputs which our experts will give us in the panel discussion. So HLA मैचिंग, अब हमने एक का कर लिया, डोनर का कर लिया, रेसिपिएंट का कर लिया, अब उन्हें मैच करना है। अब मैच कैसे करना है और किन्हें मैच करना है, ठीक है। So firstly, in the traditional days when we were students, we used to read about 8x8 matching, जिसके अंदर what we used to do, we will match at HLA A, B, C and DR B1, okay. Before that, Before that there was 6x6 जो कि umbilical cord में भी पहले ज़्यादा use करते थे। अभी तो nowadays we believe that 10x10 or 12x12 is the best, but still few people for umbilical cord still do 6x6 match, and which is HLA A, B and DRB1. When we add C locus also, then it become 8x8 match, and when we add DQB1 also, then it become a 10x10 match, and when we add the DPB1 also, then it become a 12x12 match. और हमेशा जो ज्यादा होता है वो कम से बेहतर होता है, तो जितना ज्यादा मैच करोगे उतना बढ़िया रहेगा। Now coming to mismatch HLA, अगर ऐसा हुआ that we tried for a matching but we didn't find a match donor, then what we will do? We will use the mismatched donors. So mismatched donors क्या हो सकते हैं? They can be of two types. They can be from the mud. They are donor registries, as you all know, and they provide us with the mud donors. And they are haploidentical donors. Haploidentical donors are the donors from the family members, जो कि like parents, father or mother. Father and mother are like invariably 5x10 match, ठीक है? या फिर आपका कोई सिबलिंग हो सकता है, कजन हो सकता है, ग्रैंड पेरेंट्स हो सकते हैं, या फिर आपके मामा, चाचा, ताऊ, कुछ भी हो सकता है. An initial observation that HLA B and C incompatibilities were better tolerated than A and DRB1 mismatches has not been confirmed in more recent studies. So when I was a student, the traditional teaching was कि अगर मड डोनर आप सेलेक्ट कर रहे हो और आपको HLA और B में लोकस पे इनकम्पैटिबिलिटी मिल रही है या A या DRB1 पे मिल रही है, तो go for B and C. But now with more studies, these all things have been repeated off. अब ऐसा कुछ नहीं है. But still we are the old people, we use that. Comparison of the impact of single allele and single antigen mismatches on clinical outcome did not reveal significant differences except possibly for HLA-C locus, for which allele mismatches have been reported to be less detrimental than the antigen mismatches. So now coming to the last part of my talk, which is what is the mismatches. अगर एक donor है और एक patient है, तो अगर वो दोनों नहीं मिल रहे तो mismatch है. What it means that if we talk of any locus, if I talk of A locus, तो A locus पे the patient has A and B and the donor has A and D और A and C. तो एक तो उनका मिल रहा है और दूसरा उनका नहीं मिल रहा है. तो जब दूसरा उनका locus नहीं मिल रहा है, तो what is causing? So it is causing the immune reaction. So the host cells will go and kill the graft cells, stem cells, and they can lead to rejection. And if rejection doesn't happen and engraftment happens, then later on when the donor cells become powerful, they can go and kill the recipient cells and cause the GVHD. So it is known as bidirectional. ठीक है कि graft versus host direction में भी हो रहा है और host versus graft direction में भी हो रहा है. But sometimes it is unidirectional. Unidirectional मतलब like for example graft versus host disease direction, which means that there's something, the mismatch is like something that the graft can kill the host cells, but the host cells can't kill the graft. When it happens, let's see. So when the donor is homozygous for a particular locus, ठीक है? तो ये एक example है. Here we have two individual X and Y. Okay. So for B, C, DRB1 and DQB1, जो mismatching है, जो matching है, that is every locus has one match, one mismatch. If we see B, तो ये 1502 है, 1515 है, ये 1502 है, 3501 है, ठीक है. तो एक मैच है, एक mismatch है, ठीक है, बाकी सब में ये है. But if you come to A locus, so what you are seeing, the person X has 1101 and 2402, and the Y has 1101 and 1101. अब होगा क्या, जो X है वो तो रिसिपिएंट है. जब हमने डोनर के सेल्स निकाल के इसको डाले तो these cells will not find a target to kill, because इसको तो ये दोनों हैं उसके अपने ही लगेंगे, ठीक है. But the Y cells will find a target, because उसके लिए 1101 तो अपना है, but 2402 अपना नहीं है, so it will kill the cells. So what will happen? So when the donor is homozygous for a particular locus, then you will get reaction only in one direction, which is graft versus host direction. But when the patient is homozygous for a given locus, then you will find that it is a graft versus host reaction, but not the other way around. अगर हम इसको, अगर X हमारा donor हो जाए और Y recipient, तो फिर उल्टा हो जाएगा. Okay. So from now here, I will like to close my talk. And for transplant, it is being said that if you touch one life, you touch 1,000. Thank you so much for your patient listening, and I hope I have not bored you a lot.
So I think, Neha, first of all, I need to congratulate you. I think you have kept, I think you kept your promise. You kept it very interesting.
Thank you
and
so
I
much.
think your style is very unique. It reminds me, if I'm permitted, I'm going off track for one few seconds. It reminds me, when we're younger, and Satyendra used to do some sessions with us like in that style. So he's also part of the, the faculty today. So it just reminded me of Satyendra many years ago. So, so it was really fantastic the way I think you put it. The only thing I want to tell you, please don't use too much Hindi, because I got my colleagues here who don't understand too much Hindi. So, so thank you very much. I think you made it very, very interesting and simple, and could explain, everything what you had to, tell about HLA typing. Dr. Jasmeet, you are the only expert here on HLA typing, I would say. We are all clinicians, so you have to add anything on this what Dr. Neha has discussed with us. Then we can move on to the case, the question discussion.
Yeah, so Neha, that was a nice presentation,
Thank you, ma'am.
very concise. And of course, HLA made very easy. But what I would want to tell is that we have, when you talk about HLA class 1, you talk about A, B, and C. But and class 2, you talk about DR, DQ, and DP. But these are the classical HLA genes. But HLA has far many genes which are the non-classical. And there are a few of those, HLA-G, HLA-E, G particularly, which are now getting implicated in transplant, if not directly in doing the transplant, but certain consequences of transplant. Of course, HLA-G has already been established as an important factor in recurrent spontaneous abortions, and because of its expression on the placenta and downregulation of the immune response. So that's one factor. There are centers which are also looking at DRB3, 4, and 5. So when you say 12 antigens, you could actually extend it further.
But it is basically it is for fellows, so I don't want it to confuse them.
Exactly. So it's nice for them to be sensitized to this, and they need to know that there's a lot more beyond, but this does by and large cover. The one more point is the linkage part. So the linkage disequilibrium is a very, very important factor, which plays a tremendous role when you're doing even search for a donor in a registry. There are certain parts of HLA which the concept of haplotype is that it's inherited, and the operative word there is en bloc. So when you inherit the HLA gene from your parents, one from the father and one from the mother, that particular haplotype comes en bloc. So the B and the C are in linkage more often, as are DQ and DR. So these are factors which help when we are looking at data for registries, one. And secondly, there are also certain haplotypes which are ancestral haplotypes. So we have the famous ancestral haplotype for Caucasians, and another one for the Asians, probably because the Caucasian identified earlier is called the A1 and the other one is called A2, but actually existing for a longer time. But I think I'll let you move on because we can go on forever.
Jasmeet, you have any comments on the nomenclature as well before we move ahead?
So the nomenclature, by and large, I think it covers most of it. When we look at um, the high resolution or the ultra high resolution, we go up to 4 fields. But the fourth field is actually intronic data. The first 3 fields is the exonic data, which as of today is relevant. If you go on to the next field, the last field, that is the last 2 digits, 7th and 8th, that's intronic data. Uh, we can record it if you like, but as of today, there is no literature to suggest that it has any relevance in transplantation. Yeah,
Thank
I
you.
think that's all.
Thank you, Neha. You can continue, Neha. Sorry.
Yeah. So now coming on to the next part of our presentation today, which is a panel discussion on how to select a donor for a HSCT. So firstly, I want to invite all our esteemed panelists. So first is Dr. S.P. Yadav sir from Medanta Hospital, Gurgaon. And then Dr. Sunil Bhatt sir from Narayana Hospital, Bangalore. And Dr. Satyendra Kateva sir from Soni Mahipal Hospital, Jaipur. And Dr. Jasmeet Kaur ma'am, who is in National Reference Lab, New Delhi, in Lal Path Lab. And also with us is Dr. K. Upasna. She has just joined FIAP in our hospital, and I have just grabbed her. Nobody was ready to do it in such a short time. So she's very new to the subject, okay? But she'll do the case presentation for us. So firstly, coming on to the choices in life. So this is always very yes. So it is always very problematic when you have lots of choices in life. If your wardrobe is having only 2 pairs of clothes, you won't be having any problem in your life. या तो ये पहनना है या फिर ये पहनना है. But when your wardrobe is full of clothes, then you have a problem. कि party में क्या पहनना है, शादी में क्या पहनना है, workplace पे क्या पहनना है. So our life was simple when we only have matched sibling donors in our life. But now it's not the same. So our juniors luxury, they have lots of donor options available. So we have HLA identical siblings, haploidentical family members, unrelated donors, and cord blood donors. So we can find a HLA identical siblings about 25% of the cases, haploidentical donors in more than 90% of the cases, cord blood donors in more than 80% of the doses. But for unrelated donor, I've written like 30 to 90%. So it can vary. For few, it is only 30%. But for few, it's 90%. So what's the reason behind it? So let's go to the experts and ask from them what is the reason. So Dr. Jasmeet, I want to ask you, how can we get an unrelated donor and what are the problems encountered in unrelated donor registries? Ma'am, please.
Okay, so you can get unrelated donors from donor registries. Of course, some of my other panelists will be able to tell the difficulties they encounter, but yes, I can highlight that the registries are we don't have any exceptionally great registries in India. Very often need to access international registries. There are many registries they can access. The main constraint over there is the cost. But another big factor there with the registries is that there isn't as good a representation of an Asian population or an Indian population as compared to a Caucasian. So difficulties do occur as far as looking for a donor for an Indian patient in an American or a German or an Australian or a Japanese. Actually, Japanese hardly ever registries thing. The other problem that the Indian patients would be having is that we are a very diverse population, east of India, north, south, west. Because of our diversity, we do not, we within our own population need to have various well represented pockets in registries. The other factor that is there with the registries is that not all donors are well typed or completely typed in all registries. There are some which would just do ABDR at low resolution and will move on to higher resolution, which is what NMDP would do, which is the American registry. They would then go out and do a high resolution, which further delays the time frame required to get the harvest from those registries. Uh, the other important factor that registries face is donor attrition. There are donors who are typed and kept and are not able to retrieve those donors as and when required. So I think Sunil or Sitinder or Dr. Yadav, if you all wish to add any more points to this.
Uh, so, Dr. Sunil, you want to add something?
No, I think Dr. Jasmeet has probably covered everything, and I think the point she was trying to make is that we need, I think your bracket showing that 30 to 90%. That's a problem. So when a Caucasian, a white patient looks for a patient for a donor, the chances are about 75 to 90% you'll find a full match donor for them in registries. And when you look for a Indian, for example, it can be as low as 15 to 20%.
Yeah,
So I think it
definitely.
all depends on what ethnic mix, and you need your own people on the registries, and we have both the major registries which are operating in India has around 4.5 lakh donors on them on their registries, which is a very small number for the size of our country. But fortunately, our registries have high resolution HLA typing than all the donors, which is a little bonus for us because in one go you will be able to see whether there is a fully matched donor available in the registries or not on high resolution. So that's a little advantage we have, but the registry is very small. But rest I think she's highlighted the whole thing.
Okay. Yadav sir, what is your view on what are the different parameters which we should consider while selecting a donor for a transplant in general?
Okay, thank you, Neha, for this excellent question. So that's the main question we face always whenever we are doing an allo transplant, that which donor to choose from. So obviously the first thing is HLA typing. That's what we do to see if we have a matched related or matched sibling donor available, because that's always the best choice. So our first choice is a sibling or a matched related donor who is fully matched 10 by 10. But if that is not possible, then we go to matched unrelated donor. That's the traditional teaching, that fully matched unrelated donor. And third option used to be unrelated cord blood transplant. But nowadays, with the advent of haploidentical transplants, the haploidentical transplant has overtaken cord, and cord has become fourth choice these days. And haplotransplant is giving competition to even matched unrelated donor transplant in adults with leukemias and even children with leukemias. But for non-malignant conditions, it's still evolving, the usage of haploidentical transplant. And but more and more data is coming, which is exciting, and probably haplotransplant is going to become almost a second choice after matched sibling donor in the coming years. So that's about the HLA typing. Then comes once you have, suppose there are multiple donors who all are HLA matched siblings, then you have to look at basically CMV status. That's important. And especially if a patient is CMV negative, we should prefer a CMV negative donor if possible. And if a patient is CMV positive, then a donor, if it is CMV positive, that's preferred. So usually a CMV negative donor is not something we prefer in case, unless the recipient is also CMV negative. Then comes your ABO matching. So the blood group there shouldn't be a major mismatch. That means when you're infusing the cells, there shouldn't be much of hemolysis happening, and there shouldn't be too many antibodies against the donor red cells, so that there are no immediate problems at that time, and later on engraftment issues of the red cells are not there. So if possible, major ABO mismatch, if we can avoid it, that's another thing. And then a younger donor is what we prefer in age. So if we have multiple donors on an unrelated registry, then go for a younger donor. Look for the gender of the donor. So a female donor, a male donor is usually preferred as compared to a female. And if the only female donor is available, there is no male donor available, then amongst the female donors, a multiparous female is we tend to avoid, and we go for someone who has children or is younger female. And then comes, there are multiple other factors which go into the choice of the donor. If you have lots of donors, then KI typing, which we will discuss later on in the coming slides, that is NK cell typing. And there can be then the urgency of transplant or the indication for transplant. So if it's a malignant condition and you need to do transplant urgently, then searching for an unrelated donor can take many weeks to months, and your patient may relapse by that time. So if it's urgent, then you may have to think of alternative donor transplants. These are some of the points I would say. Thank you.
Thank you so much, sir. So as sir has already covered all these points, let's go for the next thing. So now there is a case. Dr. Upasana will present the case for us. Over to Dr. Upasana.
Good evening to all. I'm here to present the first case. This is MR, a 10-year-old boy from Kanpur, Uttar Pradesh, who presented with pallor, hepatosplenomegaly, and ecchymotic patches. He was diagnosed with acute myeloid leukemia with a translocation of 821, which is a good prognosis, and he received chemotherapy of 7+3. He achieved remission after this, and this was followed by a high-dose cytarabine cycle, and he completed the treatment. He remained in remission for about a year and then relapsed. He was planned for HSCT. He had 2 siblings, and we're going to see the HLA typing according.
Yeah. Thanks, Upasana.
Yeah.
So now we have this HLA typing. So this is patient. First one is of patient. Second one is of a brother who is 6 years. And third one is of a sister who is only 2 years. So so it is, since it is a mobile screen, I just read out it for you. It is the brother was 5/10 and the sister was 10/10. Okay. So firstly, before going to what donor we should select, Dr. Jasmine, do you want to add how the HLA typing is being done?
So HLA typing for bone marrow transplant or HSCT is done only by molecular methods. There was a serological method which is by and large outdated for whatever form of transplant. So within the molecular methods, there is you could do either a low resolution typing, which would be SSP, which again is going out of vogue. There is SSOP, and there is then the NGS based and the SBT typing. So the NGS and the SBT are the higher resolution typing. And within these two, the NGS has only come in recently, but the SBT or the sequence-based typing has been around for many years. And despite the NGS, it remains the gold standard as of today. Because you look at every sequence and report. So for a bone marrow transplant, the method which is being used, if it's a sibling transplant, a sibling transplant, low resolution molecular would work at ABDR. It has worked for many and for a whole lot of years. But yes, the world has moved on to an NGS-based platform for HLA typing, and the reports you showed also are NGS results. So you can get up to 8-digit report on the NGS, which is a higher resolution typing.
Okay. Thank you so much, ma'am. So, Kateva sir, what will be your choice for donor in this patient? So we have two choices. One is brother who is 6 years, 5/10 match, and other is the sister 2 years, 10/10 match.
So hello all, and thank you Neha and the PHO chapter for
Yes,
this
sir.
wonderful conversation. So the things are very, very easy here because as sir had said, Dr. Yadav has said, whenever you are looking for a bone marrow transplant, the first thing you look for and you pray for is that maybe this patient has a matched sibling available. And there are many reasons for that, because the one thing is that we have the maximum data from these transplants, and that data gives you a lot of options from selecting the conditioning. That data gives you the courage to tell exact number to the parents that that is how it is looking like. That data gives you the most important thing, that by day 15, 14, things are going to be okay. That data tells you that in the in the fix of leukemia, you are not going to create, there are less chances that you will create GVHD. That data tells you that even if you have a GVHD, then that is going to help us later on with the available treatment, because the chances of matched sibling, there is not a rule, but once you have GVHD and it's a matched sibling, then you feel like, okay, let us try this, let us try that. And the most important thing is with the matched siblings, again, it's not a rule, that you have less chances of rejection. So whenever you are dealing with a patient of leukemia and you see a donor, which is like at least 1 year old, because then you feel like, life is easy. Now here, there are two siblings. One is like 5 out of 10, and the other one, the younger one, is like 10 out of 10. And the younger one is just 2 years. So the one of the important decision when you take a sibling, which is 10 out of 10 or 12 out of 12 match, is that is the posterior superior iliac spine going to help us during the bone marrow harvest in OT? And we think that by 18 months or 15 to 18 months, the posterior superior iliac spine is calcified enough so that we can harvest a marrow here in this patient. Now, whether you want to go ahead and do the bone marrow versus you want to go ahead and do the peripheral blood stem cells is a different question. The other thing is, when you are looking for a donor, which is a sibling donor, you want that while if you are going to harvest the peripheral stem cells, then you want at least donor to be more than 7-8 kilos, because putting a donor on peripheral blood stem cell harvest on a machine whose blood volume is a challenge is going to be a nightmare for you, for the blood bank and everybody. So here the choice is easy, because you have a donor which is 2 years old. You have a donor which is like not exposed to any antigens because she's just 2 years, and she's 10 out of 10. So I'll go with that donor which is 10 out of 10 younger sibling.
Thank you, sir. But what if the sister who is 2 years old is only 14 kgs and the patient is little obese and he's 44 kg? Is that going to give you some nightmares?
Yes, so that's what we were talking about, and we touched upon this also. If you see a gross mismatch between the donor and the recipient, then you are not going to suck the whole blood out of your donor just because it's a matched sibling. You just can't punish them.
Yes.
And that's a question, because then there is a question of hemodynamic instability. So here, because thankfully to you and Upasana, you have a patient where we are going to deal with leukemia, and the donor is 2 years. So we can take them for the bone marrow harvest, but with that, having a bone marrow, because bone marrow collections have lesser number of stem cells in comparison to the peripheral blood stem cells. So we here would want to go ahead and do the GCSF mobilized bone marrow. We give the growth factors for 4 days, and 5th day we collect it. And in that process, we get a lot of stem cells, more in comparison to the bone marrow. And then we have a lot of lymphocyte also, which ultimately adds to the graft versus leukemia effect. So it's easy choice here. We will take the peripheral blood stem cells rather than the bone marrow, and we will give GCSF to the donor, and then we will collect it. Still, there might be a chance that with the GCSF, you might not be able to mobilize enough cells. And in that case, as per the protocol of the treating unit, when to use and how to use the other mobilizing agent, your transplant physician can decide. But here it's simple. We will go ahead and do the peripheral blood stem cells because there is a gross mismatch between the weight of the donor and the recipient. It's not a rule. If you are happy, you want to start with the bone marrow, you can still do with the bone marrow. And then maximum is that you can keep the blood ready for the recipient and the donor, and you can do with that angle also. And I'll suggest if you are a new transplant center, it out which way you are comfortable. But here PBSC is a possibility, good possibility. Thank you.
So here, the point which I wanted to highlight to the fellows is that HL is the most important thing, but sometimes we need to consider about the weight also. That in this case, as Dr. Kateva has rightly told us, we can manage with little bit, doing things little extra, like we might need any extra for etc. But we need to consider the weight of the donor also in our algorithm of donor selection. Okay, so Dr. Sunil, sir, what are your comments for the selection of a donor in general? Which is a better donor, a male or a female?
Thank you very much, Neha. I think that has been partly addressed by Dr. Yadav, but I'll just put up a little perspective. Before we go that, the previous question was a very good question. I think donor safety is the utmost importance, even in a matched sibling setting, not only unrelated donor setting. So we cannot take more than 20 ml of marrow from the donor at one setting. And we need at least 5 to 10 ml per kg of marrow for the patient. So it does happen at many times that your donor is too small and the patient is quite big, and you may not safely get enough marrow at one given point of time for the patient. So as you said, PBSC is one option. The second option is, especially in the conditions where you can wait, with the normal conditions, you can do a marrow, do a red cell depletion, cryopreserve it, and do another marrow collection after 4 to 8 weeks, or sometimes even longer, and then use the both of these two together. There's also an option of the cord has been stored that we can use the cord and marrow co-infusion to give adequate cell dose. The idea is to give adequate cell dose and at the same time to have it safe for the donor to undergo donation. Now coming to this question of gender, see this gender role in a transplant setting has been predominantly relevant in an unrelated donor setting predominantly. In a matched sibling setting, we hardly have multiple choices, and so it's easier to go with
definitely.
a fully matched donor, whosoever is a fully matched, irrespective of the sex of the donor. But even in fully matched donor or in an unrelated donor setting, if you have a choice between if you have a choice between a male or a female, age, I would still say, will take a good precedence. Younger donors do better, and if you have younger donors in that setting, then we'll choose a male donor over a female donor. And in a female donor, as Dr. Yadav said, it will be better to use a nulliparous than a multiparous female donor. This has been predominantly studied in male recipients, where the patient is a male recipient. Impact of donor sex has not been shown to be in female recipients. So if there's a female patient, whether you give them a male donor or a female donor has not been shown to be of significance. Although I personally still believe that maybe multiparous females, even for female recipients, may not do as well, but that's not been substantiated by large data sets, even from the registry's point of view. So yes, if it's a male recipient, you will choose a male donor, a young male donor, or a young, that's not available, young nulliparous female instead of a multiparous female. And in a sibling setting, although it's not, I think if your question is in the regards to this patient, what we are discussing now, Dr. Satnar, I think, quite clearly highlighted that HLA takes precedence. And even though, there's a sex mismatch here, we still choose her as a donor. Thank you.
Yeah. So the same point
Neha,
I wanted to highlight to the fellows. Yes, sir.
I would just add to what Sunil has just said, that the Y chromosome in the males somehow expresses a particular antigen against which the female will have an antibody, and the female donors they can attack the male recipient because they have antibodies against the Y chromosome antigen, and that's the problem, and that's why That's the reason what Sunil is highlighting, that preferably in males, if you could select a male donor, that would be better. Thank you.
Okay, thank you so much, sir. Thank you so much. So now coming on to the next part. So it is a case over to Dr. Upasna.
Thank you, ma'am. Case 2 here, we have a 5-year-old female child with pre-B acute lymphoblastic leukemia who was referred to us from another center for BMT with the end of induction and end of consolidation. Both the bone marrow were MRD positive. She was given chemotherapy and planned for HSCT, and the HLA typing is following slide shown.
Yeah, thank you, Upasna. So this is the HLA typing of that patient. So first is a patient who is a 9-year-old and a female child, and the second is of the brother who is 12 years old. Third is of the mother who is 41 years old, and fourth is of father who is 45 years old. And everybody 2, 3, and 4 are 5/10 matches to the first one, the patient. Okay. So Yadav sir, out of the 3 available donors, whom will you choose and why?
Okay, so great question, Neha. So in haploidentical transplant, we always have more than one donor available. So usually both parents are there, and even the families ask us, whom are you going to choose the donor? Am I a better donor, or my wife is a better donor for the child? And if there is a sibling who is 50% match, if sibling is full match, obviously that is the first choice. But if sibling is also just half match, then there are 3 choices what we have right now. So at the outset, I would say that the data in haploidentical transplant with especially post-transplant cyclophosphamide approach, there's not a lot of data to how to choose the donor, like which one to choose out of these 3. But there are certain rules and certain results available on the basis of which I will just try to guide you that which could be the best donor. So one is that more HLA disparity is better. So if you have 5/6, 5/10 or a 6/10 match donor, that has better results or lesser relapse in a leukemia setting. So that has better results rather than having a 7/10 or 8/10 or 9/10 match donor that has poorer outcomes in leukemia setting in haplotransplant. So because here this is leukemia, I would go for greater mismatch. But all 3 are like, I think mother is 6/10 and other are 5/10. So practically everyone is similar in that regard.
So mother is also 5/10. It is 7/0
Okay, that's okay. So all are similar in terms of this HLA disparity. That is one thing you should look for. Then the second thing is that you look for is HLA DRB B1 matching. So if there is a HLA DR B1 mismatch, they tend to have better outcomes in leukemia. So here all of them are mismatching on HLA DR B1. So that's okay. Then the third thing is the newer data which has come is that you can do HLA P HLA DP matching, and if there is a mismatch on that, then you tend to have lesser relapse in a case of leukemia. So we haven't done that, so that is not possible for me to apply. But if that is available, that can be looked at. Then comes your CMV status, as in the traditional transplant when you have fully matched donor available. Same thing in haplotransplant also, that if out of them, if the donor is CMV positive, then we have to look for possibly a CMV positive donor out of them. That would be better. So CMV negative donor is not a good idea. Okay, that would lead to CMV reactivation. So that's important. And then ABO matching also we would look at if possible. But in haplotransplant, it's not a huge problem. We don't go. A younger donor is better, or a child or a sibling is preferred donor as compared to the parents. So here the donor which is a sibling, 12-year-old, possibly that could be our first choice if all the other parameters are also okay. But practically out of these 3, anybody can be a donor. It's not a huge problem. If the sibling is unfit or there is some issue, then we can take other also. And in terms of male or female donor in haplo-PTCY, we don't have that much of data. But generally, the data from China is indicated that male donors are better. And in general, also in transplant, male donors are preferred. But this is a bit controversial in haplo-PTCY. So I will not comment here. Thank you.
Thank you, sir. So now coming on to the next part, as everybody is talking about CMV, so I want to ask your views, Dr. Kateva, regarding the choice. If you have all the choice available in this world, what will you prefer for a CMV positive recipient and the second for a CMV negative recipient?
So thanks, Neha, and almost 300 transplant I have seen so far. But from the Indian continent and even from the Middle East, I have not seen even one patient who is CMV IgG negative. So for all the practical purpose in our country and in the developing world, we are most like CMV positive. So let us sort it out. If your patient is CMV negative, you search for a donor which is CMV negative. Otherwise, there are going to be issues. But let us assume your CM patient is CMV negative, is positive. Then what are the choices? The best choice would be, if your patient is CMV positive, you search for a donor which is CMV positive. Because CMV positive means that that donor has got the lymphocyte against the CMV. And not only that, yet the donor has got, there are something known as committed precursor lymphocytes. And among them, it has been found that these antiviral lymphocytes are also there, the information is into them. So when they proliferate, they make a lot of anti-CMV cells also. And that's the reason that when you do transplant, primarily in the first 45-60 days, till that is the time when these committed precursor cells have proliferated and their lymphocyte stays on. So we see less number of the viral reactivations. So for any CMV negative patient, please go and somehow search for a negative donor. It's a difficult, but if it is not possible, then there is some suggestion from a paper in Blood that is about the cord blood transplants. And the author's name is Milano, and that was in 2009 or 6, I don't remember, in the Blood Journal. 11. And that's about the cord blood transplant, and there he has changed the strategy.
Yes.
And what he has done is they start into the conditioning with ganciclovir, and then after the transplant, they stop it 2 days before, and then after the transplant, they continue with high dose acyclovir till like day 100, and then they stop it. And they have reported in cord blood transplant something like 28 or 30% less reactivation of the CMV. So I'll suggest that if you are that unfortunate that you have somebody, patient who is CMV negative and you do not have a donor which is negative, then that is the approach you can take. And for CMV positive, most likely you are going to get a CMV positive, but if you're not, then whatever it is there, you go ahead and do that.
Thank you so much, sir. So Dr. Kateva has already answered this question, so I'm going to the next slide. So now coming on to the concept of ABO incompatibility. So ABO incompatibility can be major, minor or bidirectional. So major kya hai ki when the recipient doesn't have the antigen which is present in the donor, and in minor the antigen is not present in the donor but it is present in the recipient, and bidirectional to dono taraf se hai. So I want to ask Dr.
Neha,
Sunil
before
sir,
the question, I want to make it simpler for everybody the way I learned it, right? So, so I'll make it simpler for the fellows and the students. So major event in transplant is that your transplant gets rejected. That's a major thing. You want to do transplant and transplant got rejected. And that means your patient has got antibodies against the antigen of donor. That is major. Minor is your donor has antibodies against the patient's ABO group, and the bidirectional is both ways A to B. So that is how I keep it. Major means patient has antibodies which can reject the donor cells. Minor is vice versa, and bidirectional is both. That is how I remembered it. That's very effective.
Yes, sir. Okay. So, Sunil sir, do you give importance to blood grouping while searching for a donor?
Okay, so first of all, I want to just mention one thing on CMV. We know that CMV negative patient, CMV negative donor, gives, is an ideal situation probably. But you have to understand that is only in the context of CMV screened blood and it's CMV screened negative blood, which is being given to them post-transplant, which is not a possibility in our setting at all. So that equation really doesn't hold true for us, because all the blood which they're going to get is going to be CMV unscreened and probably CMV positive, as 98% would be. So I think that's a caveat in our settings when we consider CMV negative. So for my sake, I think the best situation is CMV positive donor, CMV positive patient, because that's going to be realistically better. Now, coming to the question of blood grouping. So, to be honest with you, we're hardly in a situation that you have got every parameter you're ticking. You've got a fully matched donor, you've got a young donor, you've got a male donor, you have a CMV, compliant or whatever donor, and then, you have a choice of blood group. And if we reach that stage in that order, of course, you'll give some importance to blood group. And why? Although blood group, mismatching has got two implications. One is you may need some kind of graft manipulation. So if you have done a bone marrow harvest, for example, you may need to do either a red cell depletion or a plasma depletion. So that's one manipulation which is required at the time of transplantation, which would otherwise would not have been required if there was blood group compatibility. That's number one. Number two is that blood group mismatch also, although it has not been implicated too much in the overall survivals and the transplant outcomes, but it does have some implications which in the terms of events post-transplant, the most common being red cell engraftment, pure red cell aplasias, and also you can have autoimmune manifestations later on leading to hemolytic anemias and other things. So that is the implication of blood group in the context of transplant, but it should not be deterrent. If you have a major or a minor mismatch and your other parameters, have actually matched donor, they should not be deterrent. They should not dissuade you from using that donor. But of course, you need to keep in mind these two factors. You may need some graft manipulation, and also you may have some post-transplant events because of the mismatch. Now, there was a question in the chat box. I was trying to answer that, and I think one of the colleagues has asked us to re-discuss it or re-explain it, and that was on what Dr. Yadav said. 5/10 match is a better match. So what Dr. Yadav said, I think it was Debashish or I don't know who asked this question. I think it was Akshay who asked this question. So Akshay, what happens is that this was in the context of haploidentical transplant, where you have a post-transplant cyclophosphamide or also a T-cell depletion strategy to counter graft versus host disease. So the more mismatch you have, it has been shown that there will be a better graft versus leukemia effect. It is not the same in an unrelated donor transplant setting. For example, you are saying that why the 9/10, is kind of not better than 5/10. So that is an unrelated donor setting wherein you are not using any of these post-transplant, the GVHD prophylaxis like we do in a haplotransplantation. So those are two different contexts altogether. What Dr. Yadav was explaining and what we're saying there is that in a haplo setting, where you're a half-matched donor, see, for all practical purposes, 8/10, 7/10, 6/10, 5/10, they're all haplotransplants. They're all mismatched. You can consider all of them as haplotransplant. Out of them, which one to use is what he was saying is that more mismatch, probably you get to more GVL and you have a better outcome in the context of haploidentical transplantation. But that doesn't really hold true for a non-malignant disease where you don't need graft versus host disease. And when you do deal with a non-malignant disease, it's probably better to choose a more matched donor. So if you have a haplo setting with 7/10 and a 5/10 and you are treating aplastic anemia, for example, it may be better to use a 7/10 donor than a 5/10 donor. And it is vice versa for a malignant transplantation because there you need some GVL effect. So thank you. Over to you, Neha. That was the question, he wanted us to rediscuss. Yeah, thank you.
Thank you, Dr. Sunil. So Dr. Sunil has already covered this slide. Now coming on to what is the disease? So this does what disease we are treating affect our decision making in selection of donor? So my first question is to Dr. Yadav. Sir, do your donor selection algorithm changes according to the fact that the patient has a malignant or a non-malignant disorder?
Yes, so that's again an excellent question. And as I said, that when you have a malignant disorder, there is urgency of transplant. So you have to select the donor quickly and move fast. So if a matched sibling donor is available, that's the first choice. And if matched sibling donor is not available, then haploidentical donor transplant can be a good choice and we move ahead unless the matched unrelated donor is quickly available. And if it's a non-malignant condition and you have time, like you have thalassemia, you have enough time to wait. There is no urgency for transplant. So here you can take the algorithm, the matched sibling donor you have, you go for that. But if you don't have, you can search for an unrelated donor. And if you find a good unrelated donor, that's an option. If your center is doing a lot of unrelated donor transplants, you can go for that. And you can, if that is not available, then you look at the other options of like haploidentical transplants or other things. In terms of cord blood, that also used to be an option for various metabolic disorders. That still stays one of the options. So if you have a adrenoleukodystrophy, or you have Hurler, Hunter, and you don't have a matched sibling donor available, then a matched cord, unrelated cord, can still be a good option. So you can look for cord blood donors for in case of metabolic disorders, and that tends to have better outcomes. But in cord blood transplant, as Sunil has highlighted, that the cell dose is important, that if the cell dose is less, then engraftment issues are there, and the matching. So traditionally we were matching just at 6 loci, that is A, B, and DR. And on DR, high resolution was looked at, and AB, low resolution. But nowadays, high resolution report is available even in cord blood transplant, and you should try to go for a higher matching. So maybe a 6x6 on or a 10x10 or 9x10, and that may have better results and better engraftment and lesser GVHD. So these were my comments. And other thing is donor specific antibodies. So if you are going for an alternate donor transplant, like haploidentical transplant or a cord blood transplant or an unrelated donor transplant in a non-malignant condition like thalassemia, where they have been exposed to a lot of transfusions, there is a very high chance of rejection. So a donor specific antibody should be checked for, and if it's present, then maybe you choose a different donor, or you desensitize the patient. So that's another important thing, that in non-malignant conditions, those who are exposed to a lot of transfusions like aplastic or thalassemia or sickle, there is a good chance that they can reject the alternate donor transplant when it's not a matched sibling donor. Thank you, Neha.
Yes. So my next question is to you, Dr. Kateva. Does the stage of the malignant disease also impact your donor selection?
So thanks, Neha. Again, that's a fantastic question, particularly for the young pediatric hemato-oncologist. So the malignant disease, let us start an example of AML, and sometimes let us even go before that. So let us take an example of MDS. So we know MDS can be, low risk, intermediate, and high risk. And even in the intermediate and high risk, there is data that if you do transplant within 3 months of diagnosis versus after the 100 days, so the gap between the two curves is like 30-40%, 30-35%. So if you are dealing with a low risk MDS, and where you can just hang on and you can search for a donor, and you can search for a cord blood bank where a good cord blood is available. I personally think it's a big challenge to do cord blood transplant in our country, primarily just because of the neutrophil recovery in MDR sepsis, because in cord blood it's too much. But if you have something like MDS, then you can hold on to the key, and you can just hold on to the code and just search for if you have a better, and if you do not, then you go ahead and do that. But let us assume you have a high risk MDS, or you have a AML, which has been just gotten into the morphological remission somehow, right? And with the 1 or 2 cycle, and even MDR is still positive, and you know that it's around the corner that the disease is going to come back. And in high risk, if you don't do early transplant, again, there is a challenge. So in these kind of situations, rather than, keep on searching for the donors for 2 months, 3 months, 4 months, 5 months, there is a time when you decide, okay, enough is enough, and I am going to do the alternative transplant in terms of categorically the transplant and all that. But even if I take, nowadays, just a year ago, there was a paper in Blood Reviews by George, and he's a big authority on the aplastic anemia, and in the acquired aplastic anemia, he has revised the whole algorithm. So it's a review article, these are not guidelines. But in that, he has said that, okay, you have an acquired aplastic anemia, go ahead and search for a matched sibling, good enough. And then you go ahead and do the MUD search, but then he puts in a time limit of 4 to 6 at any cost. And then he goes on and he says, then don't go for immunosuppression. Then he says, then you go ahead and do the haplo. And if nothing is available, then you go ahead and do the IST. So these are not guidelines, but the newer things are now challenging the established practices. And there he's categorically saying that rather than making the patient into the high risk by giving more blood transfusion, having them an active infection solved. Rather than, doing those things, why don't we do things which are more appropriate upfront? And in that, the first data came from Seoul. And it was in 2015, the poster was into the EBMT, where they could see that the aplastic anemia patients who do not have a matched sibling donor available, and you want to do the alternative donor, it could be the mud versus the haplo, they could see upfront IST versus upfront transplant, and the difference was like 90% versus 32%. And then they also categorically said that even after IST the transplant, you come up to 60%, but upfront transplant is 90%. So now things are changing, and now for everything there is a time-bound limitation into which you have to do the transplant for the better outcomes and all that. And the senior most pediatric transplanters into the world, like Wing Leung, Paul Weiss, and the people, they feel like, rather than the type of transplant, it is, they say to me, everything is same. It is just the primary disease you are dealing with and how comfortable you are doing the transplant. So I would say that disease, stage of the disease matters, right? And, the other thing, there was an earlier question that why, in the unrelated donor registries, we are having problems and all that. I'll try to give an example. For the serological, if you have A*02, and we saw that in that serological, it was 6. But when you go down to the further, categorizing, it was like 600 and something, which means for every one serological, which was looking like a match, there were some subtype of, for every serological, there was almost 100, right? So you see how difficult is this, that things which are looking okay, but then you go down to the detailing, then you have a lot of discrepancies between the subtypes. And then in the Indian, families, we have Indian religious groups, Indian caste system. We have people where they want to stay inside their cozy group. So it's a very difficult situation sometimes to find out a unrelated donor even in the transplant registries. Though I understand that in India, whatever we have, it's small, but still the effort has gone into is massive, but still that is very, very small. So now for everything, there is now like, you put in the time limit. Okay, if it is the time you find it, it's fine. Otherwise, don't be too much, bothered about it, and let us go ahead and do the alternative transplant. Yeah. So I'll say, yes, the disease type and the disease stage matters.
High risk diseases, we have to be fast. But if the disease stage is lesser, you can wait for the donor. So, Dr. Sunil, my next question is for you. Are you doing genetic testing of the donor also for the genetic disorders? Like if you have some patient with a genetic disorder, are you doing the genetic testing of the donor also?
Yeah, it's a very good question, and very relevant in our setting in pediatric practice, especially. I had a family from Hyderabad who came to me for a transplant and HLA typing report of the patient, and there's a sibling who's a match. So the donor has not come. I said, fine, we're all ready. So we did some pre-BMD evaluation, everything was fine. And the child had Fanconi anemia. I said, okay, let's see the donor now also. When the donor comes in, as soon as she walks into the room, and I said, oh God, there's a disaster now. So the donor was also phenotypically Fanconi, although didn't have any manifestations. They had done CBCs and other things there, but there was no workup done for Fanconi in the sibling. So yes, for genetic diseases, we need to make sure that one, that especially in sibling setting, the siblings are not affected with the same disease. It has also got implications in haplotypal transplantations, where you may take one of the parents, and you have to remember that some of these diseases, most of these diseases, although are autosomal recessive, that means both the parents are carriers of that, and some of them may be just X-linked, and the mothers may be the carriers of those genetic lesions. So that is important to understand, and every disease will have to take on its merit. Using homos, for example, the same example, Fanconi anemia, using a haplo donor who is a homozygous carrier may be a good thing to do in a Fanconi anemia setting, and can be a reasonable donor if we don't have any other better donor to use in that setting. But in some diseases, for example, chronic granulomatous disease, you can have, or HLH for that matter, the donors, although they are homozygous, or heterozygous carriers, but then they may also have, they may not be the great donors because they may have some phenotype of the disease. So it's important in a related donor setting, genetic diseases, to be very sure about the disease status in the
of the donor
on the donor options. Yeah.
also.
Thank you.
Yeah. Thank you, Dr. Sunil. So, yeah, sorry. So coming now to the donor-specific antibodies. So what are they? The HLA donor-specific antibodies are the preformed antibodies in the recipient directed against the candidate donors class 1 and class 2 HLA antigens. So the classic 10 by 10 match, what we are looking at, HLA A, B, C, DRB1 and DQB1. We are not typing TPB1. तो उसके खिलाफ भी एंटीबॉडीज हो सकती हैं. So about 5% of the match sibling donors and about 80% of the match unrelated donors we are mismatched at DPP1. So I want to ask Dr. Jasmeet, ma'am, what are the methods you use for the DSA estimation, and what do you mean by MFI? Dr. Jasmeet, ma'am.
Yeah, okay. So the methods for DNA DSA would be can be divided into two. The cell-based assays, which are the conventional ones. This is the CDC cross-match, which is the old method which was used to look at presence of antibodies in the recipient against the donor cells. But the newer methods include the Luminex-based evaluation of the DSA. So the tests which are available are the single antigen bead test for class 1 and class 2 separately, which is the one which is recommended for use in haplotransplants. A new addition to the single antigen bead would be to also look at the C1q assays to see if the antibodies which are present, so it's not merely the presence of antibodies, but also we need to evaluate before the transplant whether those antibodies are complement fixing or not. So the test for that is the C1q, which is a part of the complement. So the cell-based assays is the CDC cross-match, which is a very which is a good method, but it does not pick up antibodies to the extent that would be required. Now, what is MFI is the mean fluorescent intensity, and this is the a measure of the quantum of antibodies on the Luminex-based assay. The CDC does not report the MFI, but the Luminex would report the MFI against the antigens which are present in the donor and the antibodies in the recipient. So this is something you definitely need to do. It's part of the guidelines before going for HLA mismatch transplant. So if you want me to elaborate on the DSA, then the DSA would get divided into, it's not the mere presence of anti-HLA antibodies, because anti-HLA antibody prevalence is something in the range of about 40% in patients undergoing transplant. But what you actually want to know is how much is the donor-specific antibodies, particularly to the mismatched antigens between the donor and the recipient. So is there anything else you want me to clarify?
Yeah, thank you so much, Dr. Jasmeet. Now coming on to the next question. So it is Dr. Yadav. Sir, are you doing DSA in routine to select the donor?
Yeah, thanks, Neha. So routinely, we are not doing donor-specific antibody, especially for leukemias where they are heavily immunosuppressed because of prior chemotherapy. So we haven't faced much of rejections in leukemia patients. But in non-malignant conditions like aplastic anemia or thalassemia or sickle, there we routinely do the donor-specific antibody, and that should be done. Thank you.
Thank you so much, sir. So, Dr. Keteva, sir, do you do DSA once or you do repeated evaluations like today and 1 month or 2 months apart?
So I'll again, pick upon few things which will make the understanding of our students better. So if you are desperate, let us say there is some AML or ALL and you have to do a haplotransplant, and in the haplotransplant you see only, and the father is, father and mother both are there, but there are 3 siblings and the mother is multiparous and all that. And the father has got some significant antibodies in HLA class 1 or 2, whatever. So then I would suggest that, don't be very depressed over there. Now, please send the sample for C1q estimation, because it has been found that even if it look like that against that mismatched antigen there is antibodies, but maybe that antibody is not going to, be reactive and not going to bind the complement and not going to do the damage, right? So that might help us in calming down the things, because, and that will again, reinforce us. So let us assume that we did C1q and everything, that, antibody is binding the complement and we have this. So then, this answer, how many times you repeat and all that is, the first thing is whether you are using rituximab plus plasma exchange versus rituximab plus bortezomib plus plasma exchange. Once you are done with this whole plasma exchange thing with the at least 2 doses of rituximab and 1 dose of bortezomib to clean the plasma cells, which are actually formed from B cell into the plasma cell, ultimately they form the antibodies. Rituximab takes care of the B cells and the bortezomib takes care of the plasma cells, and then the plasma exchange takes care of the antibodies which are there in the plasma. So once you have done that, never ever assume. So now let us say the thalassemia haplotransplant where you do the antibody treatment, anti-HLA antibody, and then you have 2 months before the transplant can happen, primarily because you are doing the immunosuppression cycles of fludarabine and dexamethasone. So rest assured that within some time, even if you have treated the patient well, these antibodies are going to come back. There is a very good chance that they might go up, and there are many regions that they might go up. However, there is a review article by Yoshihara in bone marrow transplant about this anti-HLA antibodies. And there in the 7 or 8 studies, it's kind of a review article or meta-analysis type of thing. There he has shown that even if the antibodies after treatment MFI is still high, but those are the patients, if you have treated them, their rejection rate goes down. So I definitely do it before treatment, then I do it after the treatment. But because of some reason, if after the treatment, there is a gap between the transplant and my test done more than 2 weeks, I repeat it again. Although I must categorically say that I will not repeat the treatment again, but before transplant, I will do 2 cascade plasma exchange. That again decreases the antibodies strength into the plasma, and the chances of rejections are better. That is how I'm doing.
Yeah. Now I have to take permission from Dr. Sunil. So it's already 5:30. So can we go ahead, or we have to stop here, sir?
Yeah, I think we can do 5 more minutes. We still have some 80 people listening, so I think it's fine. As long as someone is listening, it's absolutely all right. I think 5 more minutes we can take, please. I think I just request everyone to be brief and
so thank you so much, sir. So just a few questions, like Dr. Sunil, we know that TSA values are dependent on lab, but in general, what is your value which you are using in your practice that above that you are going to do the, you are not going to take that donor, or you are going to do something about it?
Okay, so see, I think I'll be very, very brief, and I think Satya has touched this well. DSA, any DSA is significant. Any DSA is significant. It's like MRD in leukemia settings, right? But DSA relevance would be, we have to again, dissect into 2 categories, non-malignant and malignant. Non-malignant will be more relevant because there's a high chance of rejection in non-malignant disorders. In malignancies, although, Dr. Satya Yadav sir said, he has not seen, but I have seen at least 2 leukemias rejecting with haplotransplants, who later on we realized that their DSA was positive. That was initially when we started transplant for haplos. So it is definitely a concern for both, but less in malignancies, more in non-malignant disorders. That is number 1. Number 2, as I said, any DSA is significant. And when we look at this MFI values, so there has been some work which has been done, and more than 1,000 is something which we consider as positive, and more than 5,000 is someone which is considered highly positive. And there should be in every attempt made to not select this 5,000 MFI and above donor, if at all it's possible. The moderately ones are the ones where you probably can desensitize any of these patients, any of these donors. But then even after desensitization, which Dr. Satendra was saying, that even after desensitization, even if you have demonstrated that now the DSA has become very low or become negative, they still do not reach a stage of a no DSI or a negative DSI chances of rejection. They still have high chance of rejection even after desensitization, although it may be lesser than if we had straight away gone out for the transplantation. So more than 5,000, of course, no. Less than 5,000 and more than 1,000 is something which is kind of intermediate. And again, here, if you have a choice and if you have an alternative, you choose that. If you don't have, then you probably go with desensitization strategy, whatever you use, and then take them for the transplant. And explain this to the families.
So I think you have answered most of the part of my next question, but Dr. Yadav, I want to ask you, if the patient has DSA, what do you prefer, changing the donor or desensitization?
So always changing the donor is the best option. But if you don't have any other donor, then obviously desensitization protocol will have to come in place, and you go ahead after that. So that's what I would do. Thank you.
Thank you, sir.
So Neha, there is a very, very interesting question that has come up, and just 2-3 days ago, I have reviewed everything about this question. So Manas is asking, is DSA indicated even in 10 out of 10 matched HSCT in diseases other than leukemia like aplastic? So right now I have a girl with PNH, which was taking transfusions for the last 2.5 years. Somehow it came to me, and the PNH well established by flow cytometry. And there was a platelet refractoriness because they were given not the leukodepleted, and a lot of poor blood transfusions were given to her. Now, this is the thing which is going to create a problem. Although 10 out of 10 means there is no donor specific antibodies. We don't call it DSA, but there are anti-HLA antibodies, and these anti-HLA antibodies are all known to increase the chances of GVH. There is one paper which suggests even TA-TMA, and there is some paper, that is suggesting that the transfusion requirement during transplant is going to be too high. So in that patient, though it is a 10 out of 10 matched sibling PNH, I am doing plasma exchange and rituximab and 1 dose of polymorphism, and then I'll take them transplant because that is the best possible thing. So it is not DSA, but if too much of anti-HLA antibodies are there into the screen test, they are coming strongly positive, we better treat them to decrease
so what
the
you are
GVH.
trying to say is that here you don't have a DSA, but you have anti-HLA antibodies, which we all know कि जब बहुत सारा transfusion मिलता है तो anti-HLA antibodies मिलते हैं, because of which GVHD can happen, because of which platelet refractoriness can happen. So you are not treating DSA, you are treating the anti-HLA antibodies.
Correct.
Okay. So
I think just before we conclude that, it's very important to differentiate these two. We have got students listening. Donor specific means against the donor only. When you're a 10/10 match or a 12/12 match, you will not have donor specific antibodies because they're your own self, and they're your self antigens. You will not develop antibodies to those specific HLA antigens because you also have the same. What Satyendra was saying is sensitization, which happens beyond HLA. And that happens in aplastics or whatever, whosoever is multiply transfer, whatever. But those would be, as Dr. Jasmeet was mentioning earlier, these are non-HLA players are also in the picture. And that's why we know from previous experiences, matched sibling transplants, aplastics who have been multiply transferred have higher rejection rates. And that is because of these non-HLA directed HLA antibodies. And that's a different entity altogether that doesn't come in the context of DSA. And whether we need to desensitize them, it's a good idea to desensitize them, but still is not standard of care, or we still are learning probably how we deal with those where HLA antibodies are there, but they are not specific against the DSAs.
Okay, so next is the KIR. So Dr. Jasmeet, I want to ask you, what is KIR and how is it done, and the role of KIR typing in a donor selection?
So KIR typing is done by molecular method. Again, it's kind of similar to HLA in the sense there is an antigen, there are alleles you can assign, and KIR briefly can be divided into the activating or the inhibitory KIRs. And the concept of KIR is that is important here is that they recognize or they have recognize the missing self antigen. A KIR will have it will recognize a ligand which is on HLA class 1. So the ligands can be A, B, or C, but the more important ligands for KIR are on the HLA-C locus. So depending on the presence or the absence of the ligand, KIRs are then either activating or inhibitory KIRs. The role of KIR in transplantation is they're not, typing is not done routinely, not at all for sibling transplant. In haploidentical transplant, KIR is looked at in leukemia, and maybe and based on the typing, of course, if all the other factors we've been talking all the way along, the HLA typing, the antibodies, the DSA, once all that is resolved, one can then also further to refine the selection, look at KIR in malignant conditions, and then decide between the various haploidentical donors which are available. So
thank you, Dr. Jasmeet.
yeah, okay.
Thank you. So I think this would be my last question because the time is already past 5:30. So I want to ask Dr. Kateva, are you using KIR typing in your routine donor selection algorithm?
So, Neha, I'm doing that. And, once I was given the topic of KIR, it took me some 1 month to make a presentation for KIR during my fellowship. And it's very, very difficult. But I'll try to, again, in 2 minutes, try to make it simpler for the fellows. So the KIR story started late 80s, where first we said that, there is a group Perugia in Italy. So the earlier the story started, ligand-ligand mismatch. Ligand-ligand means a substance which binds to a receptor. So initially there was ligand-ligand mismatch, and then the Perugia group said that, oh, that's a wonderful thing and all that. But remember, Perugia group did a T-cell depleted transplant. Anyhow, the same, the reports were not reported by another big group, that was the Kroger et al. There's a big paper. And they came out with a different story, and then they suggested, oh, this is not ligand only. Maybe we are now talking about ligand and the KIR receptor mismatch. And the story goes further, and it becomes the KIR mismatch. And then from the Stanford group in way back, like in 2009 or 8, there came a suggestion of haplotypes, KIR haplotypes. And in haplotypes, I would say that, haplotype A and B are important. But earlier they were saying A is better with less relapses and all that. And now most of the studies are saying haplotype B, which has got 2DS1 and 2DS2 are important. But, just to understand the KIR, that, between the patient and the donor, there are activating and inhibitory connections, receptors and ligand. But remember, whenever the inhibitory ligand binds to the ligand binds to the inhibitory receptor, the binding of that receptor ligand is stronger than the activating. That's why when you have a inhibitory a ligand for the inhibitory receptor, and once they bind, they actually takes over the activating receptors, and that NK cell doesn't kill the leukemia cells. Now the latest data is that in the haplotype B, which has got two activating, the haplotype which is 2DS1 and 2DS2, the relapses are less. But the story is different into non-malignant, where it is different because in non-malignant, it is the haplotype A which seems to be better because a lot of things are there. But let me tell you again, whatever in haplotypes, in haploidentical transplant, where we are trying to do the KIR typing, we have to remember that the majority of the Indian transplants are post-transplant cyclophosphamide. Post-transplant cyclophosphamide, with the donor NK cells, we are going to wipe them out on day 3 and day 4 with cyclophosphamide. So the first 2 to 3 days, some, the lysis of whatever GBL is going to be there, but after cyclophosphamide, we are going to wipe them out. So the story is going to be in haploidentical transplant with the same strategy is going to be different in T-cell deplete versus T-cell replete. So it's a big topic. So I'll suggest that we just go into it. Few people have made their career out of it.
I will request Dr. Sunil to give it a full talk in some later sessions of the PHO lectures.
So I'll just summarize what Satinder said. KIR is a big topic, and we need Satinder to spend another month and give a talk to us next month in the same session. That's number one. Number two is KIR context is very important, whether it's a haplodepletion, haplo replete. if I'm permitted and Sandra allows me, in T cell replete transplants, which are post on cyclophosphamide, it has got no role. If I can summarize it simply, in T cell deplete transplants, it has some role, especially in myeloid malignancies, right?
Yeah.
Not a lymphoid malignancy to that
Yes.
extent, but myeloid. So that is probably the context in simple language what we can say. But it's a huge topic, and I don't think anyone
We
has
can do justice
understood
in
it
2
very
minutes.
well how
Yes,
to
we
do it.
cannot.
Anyway, so do you have anything else, Neha? Because I think we need to wind up.
Yes, sir. I think we are not able to take the case 3, so we can wind it up here.
So I think there is only one question which has been sent to me, and that was, I think we can probably answer that question before we leave, and that was, which is a very burning question for all of us probably, is about 9x10. I think there's a question about 9x10 mud
This was an
versus, oh, there's also a question for you. Okay, so versus a haplotransplantation. So I think, to answer that question is very, very difficult, because when we read the data, and we read this data, a random data, we read that randomly our impression is that 9x10s and 10x10s are almost same. But we have to understand that in the context of what disease group has been studied in that, and what marrow graft has been used, and also probably where the mismatch has been. So first of all, I go to mismatch, and every mismatch, especially in the A, B, C, and DR loci, increases the transplant mortality by 10%. So if there's a mismatch at one of these, it's, and multiples of that, it increases 10% transplant mortality. And I think Neha initially said which one is better: A is better, B is better, C is better, DRB is better. They're all now considered equally bad. And if you see, probably one which is better is probably DQB1, because that was considered, there's a step motherly treatment to that, and it doesn't seem to be very significant. And there you can allow a mismatch. So you have to consider mismatch where the mismatch is the antigen level mismatch or an allele level mismatch, and what graft source you're using. So remember, all the studies which are especially from Europe, we say 9x10 is as good as 10x10. They are using marrow grafts, and we usually use PBSC grafts, and then you neutralize a lot of the benefit by having high graft versus host disease. So most of us, and I think my, sir can also comment, and Dr. Satendra can also comment, I personally have moved away from 9x10 mismatched PBSC transplants. If the mismatch is not at DQB1, I would prefer haploidentical transplantation over them, because in our data set, we had seen GVHD rates to about 80% in this category of patients. So we have stopped using them. You can use them if you have an allele mismatch, especially DQB1, and if you get a marrow graft, use some of these donors with marrow from DKMS, marrow we got, and that probably still okay. But overall, PBSC 9x10, I would any days choose a haplo donor transplant today over that. So that was, I think, the question which was asked, and I tried to answer that. If anything differently you think, Satendra sir, then you can probably suggest.
So, Sunil, I'll just add that if you are choosing 9x10 matched unrelated donor, then possibly post-transplant cyclophosphamide as a GVHD prophylaxis can be a new thing. Correct. Which many centers are moving towards. Thank you.
Correct.
Yeah. So we are coming to the end of the discussion. So I want to thank all my eminent panelists, Dr. SP Yadav sir, Dr. Satendra, Dr. Sunil, and Dr. Jasmeet. Thank you so much for joining us, and thanks to all the wonderful audience. Okay, thank you.
Thank you. Thank you, Neha. I think you were a wonderful moderator, and I think you did a fantastic job. And thank you.
Thank you so much, sir.
Dr. Satya sir and Satendra, and all the participation. Dr. Jasmeet needs a special mention. She was invited faculty today, and you contributed, ma'am. These lab issues were still, are still kind of very difficult for us. I think you tried to put some perspective on all these.
We could do that, Sunil, sometime.
We will do it one more session. I told you the other day, we have to do one more session predominantly on graft versus host disease immunology around it. So that will be soon. May not be on this platform, but a different platform. So we want your, we want your participation there. That will be soon.
We could look at Kir in
Correct.
detail.
Correct.
With
Kir, you and Satendra has to do. I don't think any of other people can do that. So thank you very much.
We'll do that. No problem. Thank you. Thank you, Neha. Thank you.
And I should thank Echo, who gave us this platform, and Ria in the background, who's been,
Thank you, Ria. Thank you.
And Anand and Nita again. Thank you very much. See you next week.
Thanks, Vanita.
Thank you.